All right, good evening, everybody. Welcome to another Celtic SMR webinar. As Steve said, we're going to look at today the hand and wrist. So part of the wrist will be looking at the extensor tendons. So what I'm going to do is turn your hand over. It was probably best on this one, yeah. So the extensor tendons come around here. I've got a little picture to show you, and we'll flip over to that in a second. But best way to start with the extensor tendons is always start in transverse section, and I usually start with the patient like that to get the extensor compartment 1. I'll go through the different compartments in a second with the diagram, but the extensor compartment 1 going over to 2, 3, 4, 5, and then 6. Okay, and I tend to follow those in transverse section because these are really small tendons when they get into the hand. So I tend to follow them in transverse and then just clarify dynamically in long section whether the just by wiggling the finger like this, whether the tendon's intact or not. But we'll get to that shortly. So I'll just flick over to the presentation slide just to show you the anatomy there, what we're going to cover. So this is the anatomy we're looking at. Extensor compartment 1, you can see. Thanks, Abby. APL, abductor pollicis longus, and extensor pollicis brevis. Going across to compartment 2, extensor carpi radialis brevis and extensor carpi radialis longus. Compartment 3, extensor pollicis longus, and compartment 4 is extensor digitorum communis and extensor indicis. Compartment 5, extensor digiti minimi, and finally the 6th compartment, extensor carpi ulnaris. Okay, I haven't got a mnemonic for all these, sorry, but what I tend to remember is if you look at them, it goes from compartment 1. Longus brevis, longus brevis, longus. So I try and remember that that sort of mnemonic. I remember the actual tendons, but the mnemonic longus brevis, longus brevis, longus. So that will just put them in order for you, and then I just have to remember the others. Now the star that you can see there, that's listed as tubercle on the radius, and we'll show you that when we get to the scanning. Okay. Yeah, so I think that's all. So let's get to the scanning now. So
okay, if you bear with guys for a moment, I'm just going to switch this computer over to the scanning screen.
Right, so let's move. I need to perhaps move that one. So yeah. So if you look at, it'll be my phone now, the Adrian Burman now, where you get to see the thing. So this one here where I'm waving. So start at the thumb, compartment 1 here, transverse section. Oh, screen's up here. Right, the screen, there we go. So this will be, so on the top here, let's get the arrow. This will be compartment 1. So this is APL, EPB next to each other. They're quite indistinct, as you can see. Let's have a look. I've got the 5 frequency. Yeah, I have. Got the focus at the right height, so all these settings help. But they are very small tendons, so you will get not amazing images of these superficial structures here. So this is compartment 1, APL, EPB. Okay.
What frequency do you prefer to start with there, Adrian?
Well, I'd probably start with the highest possible. So in this one, it's 17. So because they're quite superficial, so you really want the highest frequency you can manage, and that will get you the best scenario. So so what's important about this one? So this is the one where you tend to get tenosynovitis or de Quervain's veins, as you guys will probably know all about de Quervain's veins, your physios. You do your standard Finkelstein's maneuver to just correlate that clinically. So you'll know that, just doing that sort of maneuver to test that. And then what you're looking for is sort of hypoechoic thickenings. The retinaculum over here, that may be thickened. Pop the Doppler on, you may get some tenosynovitis as well. And that would be indicative of de Quervain's veins. So that's compartment 1. Now compartment 2, I'll just come across here, and you see these next two here. So that's ECRL, ECRB, so longus brevis, what I was saying earlier. That'll help you distinguish those. Now these actually cross over. If you look, if I scan up the patient's arm, you'll notice that one will go across the other. And where they cross, this is where you look for intersection syndromes, or any fluid around here. Okay. And then I follow that up, and then follow it back down onto the compartment 2, ECRL, ECRB. And you can follow those. Now, if any of these are suspected as torn or ruptured, then you can follow them distally, and you'll see disruption, and then you can obviously turn longitudinally, and if you maneuver a bit of dynamic movement to see if they're all intact. And basically, if you're wiggling fingers at this end and you see tendons moving at the wrist, there's a good chance that they're intact. So, another quick wipe of my glasses. And that's compartment 2. So, next compartment is compartment 3. Now, see this little bump here? That's where the X was on the screen. Can we nip back very quickly to that? Yeah. So that little star there is where I am now. Okay, so that's where I'm at Lister's tubercle, and that separates to compartment 2 and compartment 3.
Okay, back.
Back, cool. And there's compartment 3, which is this one, which is EPL, extensor pollicis longus. Okay, and then you can follow that because it's going over the top here. Still got it. And that will follow it to the base of the thumb there. So you can give if I get that long section, give you thumb a wiggle. Give your thumb a wiggle there, Ahmed. There we go. And that's intact. Okay, so that's compartment 3. So if you ever lose yourself, if you put that flap there, always go back to your landmark. There's the Lister's tubercle. There's your compartment 3, and then this is your compartment 4. So you've got extensor indicis and extensor communis, and then actually you can follow those, and they'll all split up, go to the digits, or you could follow the indices over to the index. Okay, so that's compartment 4. Compartment 5. Get some gel. Is here. And that's extensor digiti minimi. So if you extend your little finger there, that will move. See that moving? So he's extending his little finger. Okay. And again, you can see these are ever so small tendons. So you're following really small tendons here. Still there. Keep going a bit. There you go. Still there. And you can follow that all the way to its insertion. And then back we go. And then finally, we've got ECU, compartment 6, which sits in this sort of hammock here, like that. And this is usually interrogate this quite a bit with rheumatology, because this is a good initial sign of rheumatoid if you get sort of tenosynovitis around the ECU. So always look at that. Okay, and then obviously you can follow that one. So I always follow them in transverse section, and then if I want to confirm with dynamic imaging, need some markers for my glasses, and then just confirm in long section with the dynamic movements. Okay, so the actual wrist joint here. So this would be the first part of the wrist joint that I'd look at. This is the radial carpal recess. So proximal here, and then distal, and then look for any sort of synovial thickening. So this dark here, this is probably a little bit of synovium, that's probably a normal amount. But I look for any big bellowing of synovium here. Put the colour on. Oh. Abby might have a little bit of synovitis to the wrist. Just there. Any wrist pain, Aaron?
No, I don't think so.
Not really.
No, it's interesting. There's a little bit black in there, isn't there?
A little bit. And then you can come over to the ulnar aspect. That big black thing over here, that's a vessel, by the way. So this is the ulnar carpal recess here. There's the ulnar styloid. You pick up erosions there, the divots in the bone. The TFCC will be here, but you wouldn't look on ultrasound for the TFCC. That's more of an MRI thing. That's that part of the wrist done. Right. So this is what we've gone through there with the different tendons and where they insert. So you can follow those down. You'll see that obviously there's 2 tendons that go to the index and 2 to the little finger. It's quite very difficult to distinguish those on ultrasound, but you can obviously flex and extend the fingers just to see if anything's moving there. So once you've looked at those tendons, there's obviously presentations that you guys will be familiar with. If you go on to the next slide, let me move that down. Oh, there we go. So this you guys will probably be familiar with, and that's obviously the presentation of a swan neck or a boutonniere deformity, and that just basically tells you where you'll need to look for these ruptures. So the PIP with a central slip there for the boutonniere, and then obviously for the swan neck, it starts off as a mallet finger, obviously with the distal tendon at the DIP, and obviously the sagittal bands are holding the other bits together. So you can see that different presentations will gear you to look at different tendons when you're scanning. Those sagittal bands are very, very difficult to pick up on ultrasound. But if you know your central slip has gone or your distal bit has gone, then you can make the diagnosis that way. You don't really see the extensor hoods that well on ultrasound. It might be just look as a thickening on ultrasound, a bit of dark thickening around the tendon. Yeah, so that's that bit. Now, all right. So that's rheumatology. Now, so let's go back and have a look at the hand. So yeah, so now we'll look at the MCPs of the hand. This is back at the wrist, but this is where I've looked for initially for rheumatoid presentation. So that's that radiocarpal recess. And neurocarpal recess, looking for synovial thickening. If you do see synovial thickening, put that colour on and use the power Doppler. And you need to have your settings way down, PRF right down to pick up really small flow within the synovium there. Also look at the ECU, as I say, and then we start on the metacarpals. So here's the first MCP. So you'll see here, this is obviously the metacarpal, and then the phalanx there. This is the synovium, and you can see that it's level going straight across here, and that's what you're looking for. When you start to see this area bellowing up here, that's when you're thinking about a mild synovial hypertrophy. Okay, and obviously the more that bellows up, and the more it extends this way, and this way is how you call it from mild, moderate to severe. So when it's just bellowing, I'll show you this slide in a second, but when it's just bellowing, it's sort of mild, and when it's sort of extending over one, you could call that moderate, and if it's extending over both ends, that would be more severe. And then there's obviously a category of Doppler with that. So if you've got 1 or 2 flecks of Doppler in, that's mild synovitis. 3 or 4 or 5 Doppler signals, that's probably moderate. And then obviously if it's just very infiltrated all the way, filling up the synovium, then that's more the severe. I've got a slide to show you that anyway, to make it a bit more easier. So that's it. You may get some effusions with that as well. Effusion will sort of bellow over here. You can see that. Look for erosions. So little defects in the bone. There'll be little divots. So arthritis would be bony growths, so little spurring and bone building, whereas rheumatoid would be more divots and erosions. Now, when they're in this position, like this, you'll only see part of it. So what I'll do is I'll get Abby just to, the best way to do this is actually get them to put the hand over something like this, okay, which will give a slight bend. And then if you look here, I can see that much more now of that. I can see all this of that carpal head. So I can look for erosions down here now, and you will miss those if you don't look at those. But also don't forget this probe is giving out a 1 millimeter beam, so I also need to scan all the way over to the one side and all the way over to the lateral side, because it can look normal on the top and totally abnormal when you go over to the one side. Okay, and you do this maneuver for all the joints. So you look over the top. You can see the nice cartilage there. Nice cartilage extending over here. Now the metacarpals, you'll have this little notch here. That's totally normal. That's anatomical. So don't call this anything here. And over on this side, it's obviously a little notch here. That's normal. And then once you've assessed the MCPs, I'd look at the DIPs, which is the next one along. Again, looking for velocity of height, synovitis, and things like that. You can observe these sort of extensor tendon going over the top. With that. So I do that for each of the fingers. I can look at the DIPs as well, but it's usually what the clinical history says to have a look at the DIPs.
Can I show that little lesion I've got?
Oh yeah.
Just out of interest, I've got a little lump here on the top of a tendon.
So this here is, we looked at this the other day, didn't we, and you've got like a cystic lesion. So it's anechoic, so it's cystic. It's got posterior enhancements. I know that it's sort of fluid based. Here, this is the enhancements. So that, to me, says it's more likely to be cystic. And I think we discovered that it was actually in the tendon. So this is the extensor tendon here. So it's actually a cyst within the extensor tendon, which I think that's the first time I've seen that. You usually get little cysts going across over the sheath or things like that, but never really within the tendon. It's quite unusual. And then the reason you can tell that is if you extend your fingers there. Which one was it? Oh, that one there. And you can see the cyst moves with the tendon. So you know that's within the tendon. Very nice. Yeah, and then I look at the thumb, get a lot of osteoarthritis around the CMC joint. So this is the CMC joint of the thumb. And then MCP. And then the IPJ over here. Okay. Now you can come right to the end here. Actually, let's put your hand flat. And I'm going right to the distal DIP. And then you can pick up little. This is the nail bed, and this is the nail here. So you can pick up little glomus tumours or things here.
Subungual cysts as well. I think you can.
Yeah, absolutely.
You can see there. The nail plate.
I won't go into lumps and bumps at all because that's very much tiger country. So be very careful with lumps and bumps. But yeah. So that is the dorsal wrist in terms of extensor tendons and MCPs, as I look for on a rheumatoid case, any sort of lumps and bumps and things like that. Any questions, Steve, coming in?
Not had any come in. Oh, right on cue. Here we go. Thank you, Elaine. Right on cue. Can you show UCL thumb, please?
Oh, okay. The ulnar collateral ligaments. So this is quite tricky. Okay, so you have to get right in here, and that is basically the ulnar collateral ligament there.
Can we get the camera the other side?
So I'm coming right into the web space of the thumb here. Okay, so that's the ulnar side, and the ulnar collateral ligament sits there.
That's a good shot.
Yeah. Now, the thing to rule out with these is, because obviously if you've got something called a Steno Lesion, then the Aponeurosis, if it's gone all the way through, then it flips back and wraps around the ligament, and that's a surgical thing to sort out. So what I do, if you can, I put the probe there, get the ulnar collateral ligament, and then if I just, I've got my thing the wrong way around, that doesn't help. Now if I, I don't know whether you can see that, I'm actually just flexing and extending the distal part of the thumb. And then you're looking for a little black line that goes over the top of that, and that's the aponeurosis. And if it moves over, if you can see it swishing over there, which you can just about, it's very difficult, but there you go. That's the aponeurosis intact, so I'm not going to have a Steno lesion. So a Steno lesion will just be a bulbous mixed echo appearance that just obviously flips back this way and just forms a lump this side, and that's when the aponeurosis is mixed up with the ligament, which needs to be sorted. But this one is obviously fine. You right there, Abid?
I'm trying to get a good angle for it.
Yeah,
it's not working.
Difficult. So that's the ulnar collateral ligaments. And again, only look at that if they're querying that it's ruptured or query Steno lesion. But you can see, if I do that now, but you can see that little band running over the top of that ligament, and that's what you want. Sorry, that's what you want to just rule out that's for Steno lesion. But you can have a rupture to the ligament and that still be intact. So you look at the ligament as well, which is that dark area just bridging the gap there. Yeah, so that's good. That's a good question. Any more, Steve?
Elaine said thank you for that. That's great. No more questions at the moment, but I will prompt everyone to throw the questions in now if they can.
Okay.
Please.
I can also look at the while we're here, just go across onto the palmar aspect and look at a little bit of the palmar aspect while we're here. And obviously you've got the median nerve, all the tendons. You've got the superficialis and the profundus tendons here. Now, a good trick actually, because there's a lot in here. A good trick is to just waggle your probe, and I don't know whether you can see that all those bright tendons go dark. Okay, you can see them flashing. So all those are your tendons. Now the median nerve is the only one that's not affected by anisotropy as much. So you can literally turn the tendons off and highlight your median nerve if you're looking for the median nerve. And there it is. Yeah. If you're looking for carpal tunnel, so you can come down. There's the nerve. So it looks like a tendon almost, but if you just waggle your probe, you can see that all the others go dark, whereas that remains pretty much as it is. So that's a good way to just highlight your median nerve there. And then you come down into the carpal tunnel, you see this retinaculum over here, and that's where you measure your median nerve, and it's anything above 0.10 centimetres squared is considered pathologic. But to be honest, I'd just probably compare it with the other side, and if there's great discrepancy, then you can call it a bit.
You'd measure that with the calipers, would you, or?
Well, so what I do is I do like a trace. Now, I'm not used to this one. I've not done it on here before, but I'll give it a go. So I go caliper, and I change this to perhaps area.
Right.
See if that does it. So you follow it around. Oh, that's a bit off there. You stay inside the bright white, so it's just the inside you want to do. There we go. So this was 0.07. Can you see that at the top right?
Yeah,
So
great.
0.07, so that's absolutely fine. So if that was saying 0.10, then that would be borderline, and I'd want to look at the other side and compare and what have you.
Okay. So typically you'd freeze the screen and you just draw that.
Freeze the screen and do it
till you were
like
happy
an area trace. Yeah.
Perfect. Thank you. We did have a couple of questions come in whilst we were looking at that, or just before.
And then you can turn long section. You can see it beautifully, actually. That's all that dark one there. That's all median nerve. Okay, so you can see that the contour doesn't really change in that. So if you saw this coming down and all of a sudden there's a contour change here, like a bit of thickening, then that's, you could say, okay, then there's a little bit of neuropathy there.
Brilliant.
Nice.
Thank you. That couple of a question and a request, if we may, please. So, could you please show the triangular fibrocartilage compound?
Yeah, no, you can't. This is the TFCC, so you can't see that. It's on this ulnar aspect. It's down here somewhere. It's not really an ultrasound diagnosis. It's an MRI. So this, you wouldn't really look at this with ultrasound. So it's in here somewhere, but you can see that it's. I mean, I could probably take the frequency down a little bit. I can't. But you just can't make it out. Okay. So yeah, TFCC MRI.
It wouldn't be a Thursday evening if we didn't challenge you.
Yeah, exactly.
Okay, thank you. Thank you for the question, though, Luke. Is it usual to try and image tears in the inferior radio-ulnar ligament?
Inferior. Oh no, you see these aren't the inferior radio.
I'll say this correctly, but it's in brackets. It's interosseous.
Yeah, so it's in here. No, is the answer. These are probably MRI. The only ligament that I would tend to look at in the wrist is the Scapholunate ligament, and the way to find that is go to your Lister's tubercle, which is here. Come forward from the Lister's tubercle, and it's basically that ligament. Let me just get the arrow here. That ligament going across here. That's the only sort of ligament that we usually get asked to comment on in ultrasound. Going across there. And as I say, to find that, you go to Lister's tubercle, and it's straight off that down, and there it is. And that'll be scaphoid lunate. And you might see gapping of that joint space there. Yeah, but you can see even this. I could do bringing the focus down actually just to the right level. But even here, your visualization of this is pretty poor. But it's going across here, and obviously that can turn my frequency up, manipulate all my settings. But essentially, yeah, that's the scapholunate ligament going across there.
Okay, great.
Okay.
What ligament did you say that was?
Scapholunate.
Okay, right. Next question. Do you guys use ultrasound imaging for scaphoid fractures?
You can look at it. I wouldn't recommend looking at it solely for scaphoid fractures. If you see one, all well and good. You might see a little bit of fluid, but to be honest, you just see. So that's That's the scaphoid there. Yeah. So you can look at it, but I wouldn't use it. It's an X-ray. But if you happen to see it, then all well and good. A lot of things you can look at with ultrasound, but you wouldn't necessarily use them as the main modality to look at these things. Right? I mean, you can look at the PCL and ACL in the knee, but you don't see it very well, and I wouldn't rely on that as a diagnosis. Same with the medial lateral meniscus in the knee. You can look at it, and if you see a tear or anything, then all well and good, but it's not the primary diagnostic tool to look at these things.
Thank you. Paul, who asked that question, has come back and said, awesome, thank you. That's great. Let's cover that. Thank you. That's all the questions so far. I'll give everyone an opportunity to type away if they can, if they'd like to. Still chance to get some questions in.
Yeah.
What's the most common referral request
For the
for
wrist?
hands and wrists? Is it mostly rheumatology stuff? Or
Mainly rheumatology stuff.
are they always looking?
De Quervain's veins is quite a common one for the compartment 1. Usually, if they come in with a boutonniere deformity or a swan neck deformity, then they just want you to confirm that the tendon has gone, which you can do. And those are them.
How far do they tend to retract? Do you see how big's the gap, and do they when they completely?
Not that big, to be honest. You'll tend to see quite a stump of the tendon, be quite hyperemic. But they tend to go for those deformities. They'll go up here in the distal parts, but most of the tendon ruptures tend to go around the wrist, and you'll see a bulge at the wrist. You'll see a big stump, and then it's just a matter of tracing it back and trying to isolate which one it is. And obviously you can do your movements and stuff to help correlate that as well.
You getting many carpal tunnel requests?
No, to be honest, don't
more
see.
For nerve conduction,
Yeah,
I suppose, but
yeah, I tend to be incidental things really. I pick up with median nerve. They've got wrist pain or something, or numbness, and you just think, oh, I'll have a look at the median nerve, and you can pick up a thickened median nerve quite nicely. What else was I going to say? Oh, tubertrons. So you can get thickening to the palmar fascia on the palmar aspect. Obviously, we go back to here, and it's usually you find the tendon. See, I'm just flexing the middle tendon there, and then they usually appear above the tendon in the fascia, in the soft tissue above the tendon. There'd be like a hyperechoic defect, and then they'll be sort of knobbly, and they'll come in and they'll say, oh, I've got this lump on my palm, and it's usually thickening to the palmar fascia. If they come in with the finger retracted, so you get that sort of appearance, then it's you can pretty much diagnose as a contracture. You'll feel the nodule, and it just pulls the finger up like this, and they'll come in like that, and then that's pretty good. But it's
small.
They can be once if they start curling in, they can be very difficult to image, because obviously you've got to try and get your probe in to image it, which can be quite difficult. So it's better.
Hockey stick probably preferable for.
Yeah, the hockey stick, but even then,
don't see them very commonly in hospital settings, do they? Hockey sticks.
No. They usually the hockey sticks are usually for either injection purposes or look at rheumatology, things like that. But I mean, it's an adequate probe, but as long as it's not fully contracted, then it's quite difficult to get in. Obviously, you can look at the pulley systems. Oh, now then. Yeah. Now, if I go there, you can see. Can everyone see the tendon moving, and then above that, there's a hyperechoic area. Now that is the A1 pulley, and it looks quite thickened, I have to say, Abid.
Yes, it's too many years of the old weight training.
I was going to say too many years of somebody putting his hand in a rock that he shouldn't have done, and a number of
Stop giving my secrets away.
So yeah, so I've just put the Doppler on there just to make sure that that's not sort of hyperemic, and I'd also just make sure it's not sort of triggering, because obviously that's what trigger finger is, just thickening to the pulley, and it stops that tendon moving smoothly underneath. You can see that's moving nicely. Okay, and you can check all the pulleys. Also check it in transverse section. So you can see it's slightly off to the side there. It's there. Yeah. Move smoothly. So that's fine. Okay.
We've got another question, if we may, please.
Marvellous.
How far proximally can you normally follow the median nerve?
Yeah, well, it depends. It depends on your probe and your patient. But the thing is to try and follow it as far as you can. Obviously, it'll branch out, and once it branches out, it becomes very, very thin. Where are we? There we are. So with this one, see, I'm in the tunnel now. Fortunately, you can't see that. With the retinaculum. So if I carry on here, so now it's starting to split, and now it becomes very small. So I'm following these tiny little nerves. But if these are, if these are thickened or anything, then they're easy to follow. So if you're struggling, the chances are it's probably fine. And you can go in a long section. It's so small I've come off it, which is what happens when you turn on these small little structures. A slight movement and you go off it. So they become really difficult. But try and see it to where it bifurcates, I would say. After that, you're only really going to see it if it's pathological or swollen. Does that help, Steve?
Certainly made good sense to me. I'll give Elaine the chance to come back to me if we need any more clarity on that. Thank you.
So just looking at these flexor tendons here, you can see the...
What about in the other direction, having given Elaine the chance to come back, and in the other direction? Sorry, you were going to say, but... Oh,
in the proximal direction, it's easy. You just follow it. And it sticks out like a sort of...
That's proximal, is it?
That's proximal, yeah.
Maybe I didn't ask the question correctly in the first place. That's what Elaine was asking, was for the proximal.
Oh, sorry. So yeah, follow it proximally. You can follow it all the way up if you wanted to, right up into the brachial plexus, if you wanted to. But you'd have to obviously make sure you're well gelled up and follow it all the way up. So there you go. So nice.
You did that the other week when we were looking at something. You did you did a panoramic view. Would that work on that?
Panoramic only works in long axis. It won't work in short axis. Well, I say that you can go that way and do a panoramic that way, or that way, but you can't do it that way. Are you looking at my phone now? You need to get that. So it'll only do it with the probe in following this longitudinal. So you can go across the arm like that as a panoramic, okay, or up like there as a panoramic, but you can't do that.
Okay, all right.
Okay, I'll give it a go if you like. Let's have a look.
Well, yeah, if you don't mind. That was a question for me. I'm not sure if anyone else is interested.
How do I start? Press the update. Okay. So this is pretty poor, but you'll get the idea. So there we go. That was me going across like that, and I get a nice sort of panoramic. You can see the median nerve there in cross section, and the knitting together of all these structures here. So yeah, you can get nice images, and then going up this way. Let's try this. This is difficult because to follow this up.
That's a good one.
Something like that.
Yeah, great.
So you've got a nice. So when you're looking at Achilles tendon, it's quite nice because you want to look at how much is disrupted. Or if you want to look at the contour of the median nerve or something like that, you can see that maintains its calibre uniformly. You can look for, if you're looking for a lipoma or something, you want to see how big it is, and it's too big to fit on one width of this. Then you can use the panoramic to make a good measurement of that. I don't really want to go into lumps and bumps really, but there we go. So that's panoramic. So that's, yeah, it's a nice feature. If you've got it on your system, it's a really nice feature. So yeah, you can follow the median nerve all the way up, however far you want to go. But it becomes quite hard when you're going distally. So I was just going to quickly show you, I don't know how much time we've got, but this of the flexor tendons here, and then you've got obviously the superficialis, which so there's the flexor tendon. I don't know if you can make out if I come down. No, wait a minute. You've got the profunda that sits here, and you've got the two superficialis tendons that will split and go off to the side of that tendon, and the profunda obviously carries on distally. So you can almost pick out. There we go. You can almost pick out a Mercedes sign here, going through here. These are the two superficialis tendons. That's your profunda. Okay, and you can see those wrap around and go out to the side, and the profunda carries on distally, coming back, and then the two superficialis come back round to go on top, and then back into the main body of the tendon. There we go.